Hi, I'm Tejas Patil. I'm a thoracic oncologist at the University of Colorado Cancer Center. So with metastatic non-small cell lung cancer, there have been a lot of key developments that have really moved the needle. The biggest one has been in the immunotherapy space. We're consistently getting data to show that patients are living longer with combinations of immunotherapy, and for patients whose PD-L1 score is greater than 50%, they're living longer with single-agent immune checkpoint inhibitors. And so I think that that information really has now established what I perceive as the standard of care, which is some form of chemo immunotherapy or immune therapy in a select group of patients with a high PD-L1 score. The other advance in non-small cell lung cancer has been the improvement in availability of molecular sequencing and targeting of known driver oncogenes which are amenable to tyrosine kinase inhibitors. So in the past, we used to have a limited number of these oncogenes, specifically EGFR, ALK, and ROS1. More recently now, we've seen that KRAS G12C has emerged in the space and is an option in the second-line setting. We also have data on RET fusions, and then there are emerging biomarkers such as NRG1 fusions for which there will be potentially new targets. So I think what this is telling us is that every patient now with lung cancer really needs to get full panel of molecular testing. The era of doing piecemeal testing is, in my opinion, over. And this is good for patients because I think if we can find a targetable oncogene, we can start them on therapy that can dramatically improve their survival. Now, when we look at KRAS G12C, I think some interesting developments are happening here. So for the longest time, this was thought to be an undruggable target. And with the development of sotorasib and adagrasib, we've come to really appreciate that we can, in fact, deliver targeted therapies to these oncogenes. And so some data was presented at ESMO this year from CodeBreak 200 that looked at comparing sotorasib to docetaxel, which is the current standard of care. And it's really encouraging that despite there not being an overall survival benefit due to various nuances of the trial design that allowed crossover, one thing that was noticeable is there's a definite improvement in progression-free survival, and that sotorasib is in general very well tolerated. So I think that the future is very exciting for non-small cell lung cancer, and it's going to start to get very complicated because questions that have emerged from today have been, do we offer chemo immunotherapy first if someone has a very high PD-L1 score? And let's say they have a mutation that we can target with targeted therapies, how should we sequence these therapies? If a patient has a targeted therapy and progresses, should we biopsy them at progression to look for resistance mechanisms? If there are resistance mechanisms, what are some rational combinations? So I think these advances have been good for patients, and now what we are faced with are some very complicated questions about sequencing and how to optimize them.